Hi, I'm Alex Vaz, Director of Deliberate Practice Training at the Sentio Counseling Center. We provide low-fee online therapy and high-quality therapist training and supervision. Today's video is on case formulation and treatment planning. Hope you enjoy it. So today we're gonna do a crash course on how to do a great case formulation and treatment planning. I am joined by my wonderful SCC counselor, so at any point, please jump in, stop me, ask questions, okay? I want you to take a moment and consider this very formal, very serious image. And you guys let me know if this has ever happened to you with your clinical cases. Okay. Everyone is nodding, great. I don't feel so alone, thank you. So it's inevitable, hopefully, that you plan treatments for your clients, and it's inevitable that whatever you plan will fail. Okay? I want to be upfront about this. Whatever it is that you plan is not going to go smoothly according to plan most times, right? That's one of the reasons why we do a good case formulation. A good case formulation will not only help you plan your psychotherapy, but it will help you also predict how it will fail. It will help you predict the setbacks that you will have as you are doing psychotherapy with your clients. And so you'll be able to kind of ebb and flow and adapt as needed to your particular clients. Okay? The major resource that we're going to be working from today is from this book by the APA on the right on psychotherapy case formulation. This is by Tracy Ills. Tracy Ills is perhaps one of the biggest experts in the world on case formulation. He did a lot of research on case formulation and how it ties to treatment planning. And we're going to be focusing on an integrative case formulation approach, meaning it's a case formulation approach that works for all treatment models. It doesn't matter if you prefer CBT, emotion-focused therapy, whatever it is, you can use this treatment planning method, this case formulation method, okay? It will help you organize information for your clients and yourself. Okay, so what is a case formulation? That's the first big question, right? A case formulation is a hypothesis, emphasis on this word, right? It's not truth, capital T, it's a hypothesis about the origins and maintenance of your client's problems. Okay, so why those problems exist and why they still keep going, origins and maintenance of those problems. Doing a case formulation should help organize your understanding of the client and inform the treatment procedures that you're going to be doing. Okay. But importantly, and I really want to highlight this as well, a good case formulation should help you, the clinician, experience greater empathy for your patient. Here's a kind of a marker I have for myself when I'm doing a case formulation. By the end of doing a case formulation, which is always being revised, of course, but like the first drafts of a case formulation, I should feel something like, oh, of course that things are this way. Or it makes sense that this client would be struggling with this, right? So it actually helps with your potential kind of complex feelings you might have around the case and bring greater compassion and empathy towards your client. If you don't feel that, I would be tempted to think you still might need to tweak your case formulation. So here's the integrative model we're going to be focusing on today. It looks big, but we're actually going to decompose it, and it's going to be pretty straightforward, okay? And we're going to start with the idea of creating a problem list. From that, it may inform into creating a diagnosis. From there, developing an explanatory hypothesis. And there, all of that will help you with your treatment planning. Okay. And we're going to go this one by one. Now, if you want, you can, as I'm talking about each of these aspects, you can think about your particular client or one client that you might be struggling with. Because more often than not, difficulties you have with clients and with doing treatment have to do with either an inadequate case formulation or solid therapeutic alliance. And the two things are connected. because a solid therapeutic alliance has to do with you understanding the client, being empathic towards him, and creating a shared sense of goals and tasks. Well, you can only be empathic towards your client and have a shared sense of goals and tasks if you can create this larger picture of how your client ended up with the problems they have and what you can do about them, right? And that's what a good case formulation can do for you. Okay, so we start with creating a problem list. Now, there's a couple of things for you to think about when you're creating a problem list. So your client comes in, right? And clients, depending on the client, they usually will start with the problems that are distressing them, sometimes not. But that's exactly the first place where you want to start as a clinician, is being empathic and being able to explore and make a list of the main problems that they're coming in with. Now, the important thing that a lot of us are not trained to assess is that not all problems are born alike. So as you're collecting the client's problems and listing them, you have to assess the types of problems that they're presenting. So problems can be either vague or concrete, or they can be external or internal. Can anyone give me an example of a vague problem?
Like their belief that they're not good enough.
Okay, so a belief that they are not good enough. I would actually put that in the middle line, right? It is a specific belief. Now let's take what you just said, Vanessa. So that's a great starting point. Let's imagine the client saying, I'm depressed. Depressed is this huge thing. We don't know exactly what they mean by depressed, right? So it's kind of this vague thing. Or they could say, I have problems with my wife, right? Or I'm struggling with addiction, right? Or I would like to be more happy. Sometimes it happens, right? Which is kind of stratospherically broad, right? A lot of clients come into therapy at this broad level. And one of our tasks is identifying problems as concretely as possible, right? So when the client says, I have trouble in my relationship with my wife, we have to ask, can you give me a specific example, right? What happened with your wife? What was the last instant that's a good representation of a problem with your wife? When does it happen? How does it happen? Where does it happen? And this is all our task, because sometimes clients do not come in with that level of concreteness. Sometimes they do, and that's great, right? Now, there's this other distinction between external and internal. Anyone want to try venture a guess of an external versus an internal problem?
Guessing an external would be something that is causing, an issue, and an internal is something that you feel and is bringing up issues.
Great. You want to try an example?
Yeah, so like external would be me and my partner got in a fight last night. Internal would be I'm feeling really insecure in the type of partner that I am.
Great example, Daniel. And let's make it even more aggressively external, because there it's still a mix. Aggressively external would say, my problem is my wife. My wife comes in and does this and that, and I hate it, right? So the focus, like in their mind, the problem is outside of them, right? Versus, let's imagine internal, my problem is I have angry outbursts when my wife does X, right? But the focus is on myself, internal, right? Why is this important? And they don't teach you this in a lot of schools. We can only help people with concrete internal problems. Think about the cases where you feel stuck. I would venture that some of them, it's because you're talking about the client's problems either in a too vague manner, or you're being brainwashed into always talking in externals, focusing on things outside of the client's control. Now, I want to be clear. Our clients don't do this on purpose, okay? It's not like they wake up in the morning saying, I'm going to be vague and external to my therapist today, right? It's part of, a lot of different reasons why that happens, but they do need our help when we're doing a problem list of going from vague to concrete and from external to internal, okay? And I would actually invite you to write down their problems, their stated problems as you do it, so that you can assess this. Okay, is this vague or concrete? Is this external or internal? Okay. Finally, as you're doing this problem list, keep checking on which problem the client most wants to focus on. Right? We want to also make sure that we're engaging with their own motivation to focus on problems that make sense to them. Lastly, you're going to notice in this kind of little image here from that formulation map that there are some red flag problems that we want to pay attention to. And these are substance use, domestic violence, suicidality, homicidality, and neglect. If these appear, we probably want to give them priority. So I'm just giving you a heads up, right? It doesn't mean that all of your focus will be on these issues, but these issues are usually so important and so hindering to therapy progress that you'll just have to focus on them, right? So just keep that in mind. And sometimes the clients actually don't want to focus on those issues, the red flag issues, and want to focus on something else. So then there's some negotiation that might need to happen, okay? And finally, when it says they're functioning self, interpersonal, societal, it's basically problems around their relationship with themselves, their view of themselves, right? Their view of others and relationships with others, and with society at large. So I want to be clear about something, because I have noticed in a lot of people I've trained over some of these years, is that it's easy sometimes to confuse problems, assessing problems, with establishing treatment goals. Just because you've assessed a problem doesn't mean that the client wants to focus on it, and doesn't mean that you've established a goal. Okay? So if you have established a problem that the client has obsessive compulsive disorder of a specific type, right? We can't, first of all, assume that that's their primary focus for therapy. And we can't assume what goal that you're going to establish from that particular problem, right? So goal establishment is actually a different phase. It's further down the line. And I would actually not even think about establishing goals right from the get-go. Okay, until you have a solid sense of the problems the client is facing, you can even not think about goals, if that helps, right? Just focus on the problems and creating a really good problem list, okay? What's interesting about problems is that usually they might lead to a diagnostic label. So if you think about it, what is a diagnosis? A diagnosis is often a list of problems, things that have happened or are happening that are problematic for a person, right? So a pro of having a diagnosis is that it does help you to search for theory and evidence about that specific diagnosis, so that it then informs later stages of treatment. So if, for example, I just assessed the problems of my client, and as I'm kind of doing the list of problems, I notice, wow, all of this really feels like PTSD, right? I mean, they're having all these classic symptoms of PTSD. Well, maybe I can at least use that general label to collect more, to go read more about theory and evidence to help this person, right? So diagnosis does have that pro. It's very helpful in that sense. Where it's not so helpful is that it does not take into account the specific contextual factors of your client, okay? So that's why we have to be careful about diagnoses. It can be helpful, but it doesn't take into consideration other factors that are important for that client. For example, their specific upbringing, their specific relationships and life context, right? And all those can be equally important or even more important than the symptoms on the checklist, right? So just be careful with making diagnosis the end all and be all, but it is helpful to kind of orient you in later phases as well. Here's an example. Let's imagine that I just assessed the problems of a client, and client says that like it appears that this client has some PTSD symptoms, right? And then I go read more about PTSD, and I find a vast literature on the common aspects of PTSD, which helps me, the clinician, better understand the life experience of this patient, and you can better understand them. So for example, for PTSD, the classic symptoms would be hyperarousal and hypervigilance, having negative thoughts and mood, being actively avoidant of certain spaces, for example, or memories that could be reminders of a traumatic event, and re-experiencing, for example, for traumatic memories, re-experiencing traumatic episodes, right? So all of these together, we could call PTSD, right? And again, the label in and of itself for some people is helpful. Some people actually feel better just by having a name, something to call what they're experiencing. Other people don't particularly like labels and diagnosis. Okay, so this is again the level of getting personal. Is problem list no one has a problem with usually. You can collect a problem, it's very specific to that client. The sharing of a diagnosis might or might not be helpful depending on the client you're working with. Okay, so just keep that in mind. Okay, so we created a problem list. Maybe it informed a diagnosis. And again, all of this is tentative, right? And people can have criteria for different diagnoses. That's actually very common. It's called comorbidity, right? A lot of people have multiple criteria for multiple diagnoses. And then we move to developing an explanatory hypothesis. And this is really what case formulation is all about, okay? The explanatory hypothesis is perhaps the part you're going to spend, I wouldn't say the most time with, but it's probably the one that's going to be the most helpful for you long-term and for your client, right? This is where the learning starts to happen. Because up until like in the problem list, usually people are relating back to you things they already know. But once you get to an explanatory hypothesis, you're kind of putting everything together, and now you're kind of co-learning together about what's maintaining your client's problems, right? So an explanatory hypothesis tentatively explains why the client has their problems, its origins, and what keeps it going. And notice that when you're developing an explanatory hypothesis, one of the sources you can go back to is theory and evidence. Like the diagnosis, of course, we want to see about the specific client, but there are some things that will be universal across clients. So for example, let's go back to my example of a PTSD case. Even without knowing anything particular about that particular client, if we have established that they have the symptoms of PTSD, I can go read theory and research on PTSD, and it's likely that I will find important aspects for my explanatory hypothesis. What's keeping the PTSD going, more specifically, right? It's called the maintenance factors. So for example, in PTSD, if you go read about this, usually what keeps PTSD going is that there are still unprocessed traumatic memories. There are unhelpful beliefs about the trauma that are still present. They still have these unhelpful beliefs, and they are actively avoiding and using safety strategies, right? So these all fall under the maintenance factors, things that are happening right now that are keeping the problem going, right? This in and of itself for a lot of clients is already very helpful, because a lot of clients experience distressing emotions without really understanding what's keeping them going, right? So collaboratively helping your clients understand why their problems keep happening, right, over and over is already a very clinically useful tool. In some cases, I won't say the majority of cases, but in some cases, it's the most important part of the work, getting a sense for what's keeping the problem going, right? So it's an essential part, and you can use theory and evidence as part of explaining this explanatory hypothesis. But then we have to get specific about your specific client, right? So beyond these kind of general resources you can go to, we have all these components you're seeing here on this image, right? And I'm just going to quickly go over each of these: precipitants, origins, resources, and obstacles. And all of these are specific to your specific client, okay? So as you're, let's imagine, writing down your problem list, now you can start to write down, you can actually write down or ask, if you don't know, precipitant factors, origins, resources, and obstacles. And a lot of your questions can be targeting these different elements. Okay, so precipitants are recent or current events that trigger the problems for which the client seeks help. So precipitants are things that are triggered that are more current, right? That could be a relational breakup, a change in job, an illness, and often precipitants are what brings people into therapy. Sometimes people have been dealing with problems for a long time, but there was a specific trigger or a specific precipitant that really enhanced their symptomatology. And so now they are really motivated to seek out help, right? Anyone, without disclosing too much information, anyone can remember from their clients any precipitant factors that your client may have had?
My
Yeah.
client has abandonment issues,
Mm-hmm.
so he's having interpersonal relationship issues at the present moment.
Great. So at the present moment, there's a client that's having difficulty in the relationship, right?
Correct.
Maybe there was a spike of conflict. I don't know, right?
Mhm.
And so let's imagine that there was a spike of interpersonal conflict. That would be a precipitant, although that wouldn't explain the vulnerability or the origins of that conflict, right? That would be a different thing. Great. Daniel, you were also going to give an example?
Yeah. I have a client who goes to college that is currently on strike with some of the teachers, and it's causing a lot of anxiety and stress for them.
Great example. Great. So this is a very specific event that's triggering the problems, right? More complex trauma, personality disorder cases, usually it's harder to find precipitants, although they may exist, because sometimes like the problem is just so ongoing for so many years that it's just happening all the time. And sometimes the precipitant is not a precipitant to trigger problems, it's more a precipitant to go seek help. So precipitant might actually be a positive thing. So for example, I had a complex trauma client recently who the final straw to seek out help was actually a positive thing. It was a relationship that this client was in that encouraged them to seek out help, right? So that was a recent event that helped them seek out help. But in most cases, we're looking for precipitant triggers, recent triggers for the problems they are having, right? The origins side is past experiences that help us understand the client's vulnerability to these triggers. And these usually touch or frequently touch on developmental issues. So let's imagine a client with obsessive compulsive disorder. Maybe they are now in a relationship or in a job where their OCD is acting up much more aggressively than in the past, right? So there's a precipitant for their OCD to spike up. However, there's probably some much further down past experiences that made them more vulnerable to these symptoms, right? So asking about origins, which is usually collecting information about upbringing, messages they received from parent figures, for example. The important thing is trying to relate those back to the specific problems, right? It's not just asking origins, asking about your upbringing just completely broadly, like what was your mother like, what was your parent like, that could be helpful. But more concretely even, or more helpful even, let's imagine a client who is extremely self-critical, right? Is always criticizing themselves. Then we can look for origins of that self-criticism, and often we may find a self-critical parent, right? So that self-critical voice was actually internalized early on, right? That would be an origin factor, right? So having a sense for precipitants and origins can be helpful. And also something that often we forget to do is assessing the client's resources. So client's resources are what the client is or was able to do or has in their lives despite of or in the face of their problems, right? An example of this is the client being able to have self-care, having social skills, having developed a loving relationship with a loving partner, having a job, having friends and social support. These are all great things that we actually want to affirm and highlight because they will probably be useful for the therapy process itself. So one thing that research has found is that it's usually a good idea to incorporate clients' resources into therapy. Okay. You can incorporate them just very kind of indirectly by simply acknowledging them, praising them, affirming them. Like, it's so great that despite all of this, you've been able to do X, Y, and Z, or you're still able to do X, Y, and Z, right? Or you can actively try to use those resources for the therapy work. I'll give you a personal example. I had an anxiety disorder client, and the client had very severe social anxiety, but had a very loving partner. So one thing that we were able to do was to enlist the partner to help this client with their exposure work. So as the client was going to do exposure work for their social anxiety, we did specific tasks that involved the partner so that whenever anxiety got too high, the partner could jump in, help out, etc. Right? So you can actively encourage the use of resources throughout therapy as well. And finally, we also want to kind of have an eye for obstacles that might come up, and obstacles might be internal or external. And these are factors that hinder change, right? It might be the client's lack of motivation to work on a specific problem. It might be substance use, lack of social support, being in an abusive social environment. I want to highlight that obstacles overlaps with problems, with the creating of a problem list. Okay, so when you create a problem list, for example, you might list as a problem that the client has an abusive social environment. That would also count as an obstacle for therapy. Okay, something you have to take into consideration for your explanatory hypothesis. So again, think about your clients. First task, trying to create a really solid problem list that makes sense to both you and your client. From there, you might be able to have a label of a diagnosis, which you may or may not share, depending on the client. You try to develop an explanatory hypothesis based on things you can read, theory and evidence, which is more general, and specific components from your specific client's life. The precipitant factors that might have triggered these problems, origins that might explain their vulnerability to these triggers, resources that they have, things they have and can do despite these problems, and obstacles that probably will hinder change. The core hypothesis, the last thing that's here, is basically bringing it all together. So a core hypothesis can usually be written in a single paragraph, where you say, okay, so the client has these problems, has this history, has this precipitant factors, these resources and obstacles. Because of all this, right, these problems that they have keep going on, right? Your core hypothesis is basically a hypothesis for why are these problems still happening based on all of this information that you collected. Depending on the type of therapist that you are, you may or may not want to share your hypothesis. I personally do. And a lot of therapists do subscribe to this kind of transparent, collaborative case formulation. And so you might just literally share and ask your client to give feedback and revise your core hypothesis. Say, so you told me about these problems. We know a little bit about the origins and precipitants. And also it seems like what's keeping the problems going might be this, this, and that. Is there anything I'm missing? Anything that might be important for us to also consider, etc. Vanessa.
What if your client says that they can't really remember their childhood or anything from that time?
So that often happens actually, right? And in traumatic events that might happen. I would put it a bit differently, which is, first of all, a consideration. Is that fundamental to your understanding of the client's problems? Because sometimes you can make a pretty good explanatory hypothesis without having to necessarily get a super clear picture of origins, especially of early upbringing, right?
Mm-hmm.
Having said that, there are techniques where you can try to flesh that out a little bit. For example, there's chair work where you can invite the client to talk to an empty chair as if they're talking to their parent. And through doing that type of work, you might actually find out some aspects of their relationship that weren't so clearly in awareness, right? You can also assign certain types of homework where you can ask them to kind of go back to pictures of themselves as kids. They can kind of do some kind of detective work on their own life if they're motivated to it. And you can kind of collect information along the way, right? I will say, and this is, again, there's a lot of different perspectives. This map is pretty integrative, so any therapy model would fit into this map. But for the most part, a lot of your attention should be spent on maintenance factors, things that are happening right now that are keeping the problem going, okay? And talking about origins is usually only so helpful in as far as it helps us understand the current maintenance factors and what we can do about them now, right? So notice that all of these elements, creating a problem list, diagnosis, and then a really solid explanatory hypothesis, all of this then feeds into treatment planning, okay? I would even say that you can't really do a solid treatment planning without having done these things before. Or put differently, a treatment planning for the most part is doing a really good problem list and explanatory hypothesis. And notice that it's when you get to this part of the planning the treatment that you then start talking about goals. Up until this part, we haven't talked about goals, right? We've just been collecting information, what's distressing the client, what do they want to talk about, why those problems might be happening, but we're not assuming that they want to work or change the problems or how they want to work or change on those problems, right? So you're going to notice there's some set point considerations here about clients' reactance, preferences, culture, readiness. I'm going to focus on, not saying that it's more important than the others, but I'm going to focus on a particular one, which is readiness. Okay? Because this is often where therapists get the most stuck, and it's probably the thing that you can focus on the most to help you with your stuck cases. Okay? So let's imagine that. I hope that after this session today, you go back to supervision thinking about these factors, and maybe you can actually write out like, oh, do I have a problem with for my client? Maybe I don't actually know it that well. Maybe I have to ask them some more about their problems. Do I know about precipitant factors, their resources? Maybe I have to ask them more about this. Once you get then to this aspect of treatment planning afterwards, now let's talk about their readiness for change. And I think many of you might be already familiar with this concept of stages of change. I see some of you nodding. So one way of thinking about the client's motivation for change or for working on change is using the stages of change, which was Prochaska, Norcross. There's a lot of research around this. Basically, you can assess how motivated is your client to work on change and to work in therapy, right? And so broadly, you can assess them as being in pre-contemplation, contemplation, preparation, action, and there's actually another one, which is maintenance, which I'm not including here because you probably won't find clients right now that you're seeing that are in maintenance. You're probably going to be seeing clients that are in one of these 4 stages. We could spend a whole hour just focusing on this particular table. I'm going to invite you to by yourself kind of read a little bit about this. I can send you some more resources about this if you want. But often, this is one of the places where you get stuck. Because what sometimes happens, or I would say often happens, it's happened to me constantly, it still happens to me, is once you've talked about the client's problems, we might immediately assume that the client wants to work on those problems. And reality will remind you that often that is not the case. The nature of most psychotherapy is working with ambivalent clients who are uncertain about change or how to go about it, okay? So again, for a client that you might be stuck with and that you're bringing to personal supervision, I would try to have a sense for which stage of change they might be in for the problems that you're discussing, right? So for the main problems that you're focusing on and that they want to talk about, are they in pre-contemplation? Meaning they either don't see any problem or they're unwilling or unable to change. This is what happens with externalizers. For example, a client that again says, my problem is my wife. My problem isn't me. My problem is this other person. It's the government. It's this external thing, right? And the problem with that for therapy is that we can't really change that. We can't change the wife. We can't change the boyfriend. We can't change the government in therapy. We can only change internal things under the client's control, right? So if you assess a client as being in pre-contemplation, we have to listen. The main tasks that you want to go for is listen curiously, subtly start to raise awareness of the client's problems, ask targeted questions about what might be distressing them, and avoid pushing them to commit any change. Because your temptation as a therapist might be to try to overwork and try to convince the client that they should be changing something, right? And this will usually backlash. You're just going to get into a rupture with your clients, okay? So try to promote awareness of the client's problems, not trying to push them to change. Often, I would say a good majority of clients that you're going to see are in contemplation, which is they do see a problem, but are ambivalent or uncertain about working towards change, okay? In this stage, you're going to want to praise the client for being aware of the problem. You can give information or kind of collaboratively create rationales about the maintenance and origins of the problem. You can do tasks like do a pros and cons list for change. And again, the pros and cons isn't you trying to convince the client, okay? You're not the one saying you should change. You're asking, yeah, why would you change, right? Given these problems, what would be pros and cons for changing? And you could, for example, do values work, which is what are your core values as a client? Could these problems kind of be keeping you stuck? And would you like to kind of work towards meeting more of your core values? These are only some examples. There are other tasks you could do in this stage. But notice that, again, you're not trying to convince the client to change when you're here, okay? This is going to be the number one trigger point for you, the therapist, is clients in pre-contemplation and contemplation. You're going to be like, why doesn't my client do X, Y, and Z, right? And then you get very frustrated because they didn't follow up on the homework or they weren't excited about some technique that you presented or something, right? At this stage, only focus on the ambivalence and flesh that out, right? Once they are motivated for personal change, they're in preparation phase, right? They want to change, but they don't know how to do it. At this point, you want to focus more on the present and the future. You want to give information or co-create rationales for how other people have changed, other people in similar circumstances have changed, right? And help identify appropriate change strategies. And here's where we're really getting into treatment planning, right? And once you start reading books on, like, let's imagine a client with PTSD, then you can start thinking, okay, what are change strategies that we can go about to help you with this, right? But only at this point, when you have a clear green light that the client wants to focus on this and is willing to do the personal work to help themselves, right? And finally, once you've kind of settled together what the client could do about their problems, or what you in therapy together could do about the client's problems, then you get into action stage, which is taking those actual steps towards change. And this is where you actually implement the change strategies, which could be exposure work, it could be chair work, it could be providing techniques of mindfulness relaxation, it could be assertiveness training, a lot of different things, right? But the action is really where sometimes we're the most comfortable with, because you can use forums, you can get creative and try different experiments, you can challenge the client with homeworks, give them resources for them to read. Because this is the ideal point where the client really wants help and just wants you to give them more and more so that they can help themselves, right? What I want to point out is that often we unwillingly work with a lot of our clients as if they are in preparation and action, whereas they're actually in pre-contemplation or contemplation, okay? So if you're stuck with a client, I would be tempted to think, okay, what stage, how's my client's motivation towards change? Because I might be kind of going too fast and presenting possible techniques for them to help themselves, and you see that they're kind of disengaged, or if yes, budding you, and those are markers for you to kind of slow down, right? Once you are in preparation and action stage, then it's proper treatment planning, and you have millions of books that you can go into. And here at the SEC, you have that those client guides and forms and all of those good protocols that you can use. And so, for example, if you have a case of PTSD, there's some very clear theory and research-based protocols that you can do, that you can share with your client about what you can do to help them. You can say, okay, for this case of PTSD, we're probably going to need to do some trauma memory processing. There are specific procedures to do that. We're going to have to work to change specific meanings of what happened with the person, how that impacted your view of the self, others, and the world. And we're probably going to have to help you reduce unhelpful coping strategies and safety behaviors, right? And notice all of these 3 points here. It's an example. These are all general, right? This would apply for broadly any PTSD case. But then you'd have to translate this into your particular case. So for example, if one of the strategies is to reduce unhelpful coping strategies, now you have to assess what are the specific unhelpful coping strategies of your client, right? For example, your particular client might binge drink whenever some traumatic memory pops up. And you can be empathic about it. You can say it makes total sense that you'd have this coping strategy. In a way, it kind of helped you in the past, but unfortunately, it's also keeping the problem going, right? So what we can do is find alternative coping strategies that will be more helpful, right? But again, this level is already when you have a clear client, a client who's clear about wanting to work towards change. Lastly, thank you for bearing with me. I know this is a lot of information. You can always go back to this. Lastly, I want you to realize that although we go through these stages of creating a problem list, diagnosis, explanatory hypothesis, planning a treatment, this is actually a part of a bigger picture where we're formulating, we're trying out things. It says treat here. I would translate it into trying out things, and then monitoring progress, which you're doing objectively through outcome monitoring and measures, and subjectively by asking, okay, we've tried this, how did it go? And importantly, what usually happens as you try things out and monitor progress is you gather new information and you revise or add to your formulation and treatment plan, right? So if a client tries out an exposure work, then they can bring back kind of things that didn't work out, things that worked out, and that might actually inform again the problem list, diagnosis, explanatory hypothesis, and your treatment plan. So I would say, broadly speaking, that your first draft of a treatment plan can happen between the first and third session with a client, but it's never set in stone. Okay, it's something that you're always revising pending new information that's coming in.